My name is Anthony Rossi, and I will be presenting a case study on one of my patients who is an offensive lineman for our football team who had suffered a grade 2 ACL tear. The objectives of this presentation are to present to you the patient's history, the objective findings of the evaluation, the initial impression and course of action, the initial outcome measures that were collected, the pain intervention method that I selected, my reasoning behind selecting that pain intervention, an explanation of how I implemented the intervention, presentation of the outcomes collected through the course of the treatment, an explanation of how I believe this intervention actually affected my patient's pain, the patient's current status, some follow-up outcomes that I have collected since my patient's discharge, some clinical pearls, and my references. This particular patient was a 21-year-old male who was a senior offensive lineman for our football team. During field goal practice one day, he was struck on the lateral aspect of his left knee by a diving defensive player. When he was evaluated on the field, the patient reported that he felt an inward stress, or a valgus force, to his knee with some rotation. The patient denied feeling a pop. The patient also denied having any previous history of knee injuries. Our orthopedic evaluation in the athletic training clinic revealed that the patient was point tender over his MCL, especially just inferior to the medial joint line. The patient presented with moderate swelling over the medial aspect of his knee and superior to his patella. He was unable to bear any weight on his left leg without pain. The patient's strength was not evaluated at this time due to pain. The patient had full passive knee extension, but the last 15 degrees felt bouncy. The patient had 90 degrees of passive knee flexion before being limited due to pain. Special tests revealed a positive Lachman's with a soft end feel, a positive anterior drawer with a soft end feel, a negative posterior drawer, negative patellar apprehension, positive McMurray's with pain over the medial joint line, negative varus stress at 0 and 30 degrees, negative valgus stress at 0 degrees, but a positive valgus stress at 30 degrees with pain and minimal laxity. The patient's history and objective findings led my coworker and I to the initial impression of a grade 1 MCL sprain, but we also felt that we needed to still rule out a medial meniscus tear and an ACL sprain. Therefore, we decided to refer the patient to an orthopedic surgeon for further evaluation and hopes of getting an MRI. Prior to his MRI, the patient started working with my coworker and performed some conservative treatment and rehabilitation, such as game ready, E-stim, quad sets, ankle pumps, etc., until the MRI results came back. The MRI findings reported a grade 1 MCL sprain, no meniscus damage, and what the orthopedic surgeon identified as a grade 2 ACL sprain. This was an interesting case because the patient is a senior and is planning on graduating in the spring, so he was not interested in taking a medical redshirt in order to save his semester of eligibility. So then I started working with the patient around 12 days post-injury because my coworker asked me if I had any ideas on attempting to allow the patient to compete with his injury. The table presented on this slide shows the outcome measures that I collected on the patient's first visit working directly with me. Unfortunately, I do not have any outcomes for the first 12 days of the patient's injury. The patient's main complaints at this time were pain on the medial aspect of his left knee and feeling extremely unstable when attempting to utilize his left knee. The patient was fitted for a custom DonJoy Defender brace with the hopes of being able to compete again this season. At this point, the patient's range of motion had improved to within normal limits, his swelling had decreased, and he was no longer point tender over any aspects of his knee upon palpation. So, to begin working with this patient, the pain intervention method I decided to implement was total motion release. As you all know, TMR is a paradigm that allows for evaluation and treatment of body motion imbalances. It was initially based on a foundation of 6 exercises known as the Fab 6. These exercises were implemented by Tom Delonzo Baker because they address the largest joints in the body, they are all functional motions that the body assumes throughout the day, and each of them occurs in one plane of motion. This paradigm is related to the concept that the body is a unified system striving to maintain a dynamic center of gravity. Therefore, pain or dysfunction in one area of the body may be affected by movements that take place elsewhere. TMR treatment includes repetitions, static holds, or some combination thereof, and should be performed to the good side or the side of ease. At this point, there is limited research to the particular mechanisms by which TMR works, but 2 of the concepts that I feel are encompassed in this paradigm are regional interdependence and cross-education. Regional interdependence refers to the concept that seemingly unrelated impairments in a remote anatomical region may contribute to or be associated with the patient's primary complaint. That is why sometimes we are able to treat a patient's low back pain by having them perform a straight arm raise. Cross-education refers to performance improvement of the untrained limb after a period of unilateral practice of the homologous contralateral limb. Some articles have shown that cross-education of strength has been attributed to neuromechanisms since it is unaccompanied by muscle hypertrophy. At this point, the neurophysiological mechanisms of cross-education of strength have not been specifically identified. It is believed that this may be caused by changes in neural activity or neural circuits, but we are unsure of the site that this actually occurs at. It could be at the cortical, subcortical, or spinal pathways. Peripheral neural adaptations may occur in both limbs in response to unilateral training, including increased agonist activation and decreased antagonist coactivation. Aside from the possible mechanisms that TMR utilizes, why did I choose this paradigm as my method of intervention? Honestly, the main reason is probably because I had just completed the TMR Level 1 seminar and was interested in utilizing this paradigm with my patients. Also, during the seminar, Mr. Baker spoke about a tennis patient that suffered a complete ACL tear, and he trained the contralateral limb with ballistic or proprioceptive exercises, and they were able to compete on the injured knee. Since my patient's main complaint was a feeling of instability when he utilized his left knee, I knew that I wanted to work on ballistic and proprioceptive movements. However, I was not about to try and have this patient perform these exercises on a knee with a partial ACL tear. So that is why I decided to give training the contralateral or good knee a shot. The first step I performed with the patient was I had him perform the Fab 6 motions in order to identify any asymmetries that he had. Surprisingly, the patient did not appear to have any asymmetries and did not subjectively rate any of the motions as painful or dysfunctional. So next I decided to test out some sport-specific motions to see if there were any differences from left to right due to his knee injury. This is when the patient reported that it was more difficult for him to go from his football stance to his right when moving forward, and more difficult to go from his football stance to his right when moving backward. Aside from having the patient go from his football stance forward to the left and backward to the left, I had the patient perform the ballistic proprioceptive exercises in the table on his good knee only over the course of 7 visits. It took me some time and explanation to get the patient to buy into this treatment paradigm, because he was very confused why I would only let him do things on his good knee in an effort to make his bad knee feel better. Luckily, he decided to trust me, and collecting his outcome measures allowed me to show him the improvements that he was making. The table in this slide are the outcome measures that I collected from the patient's 2nd through 8th visit. As you can see, it didn't take very long for the patient's perceived pain intensity to decrease, but it did take about 4 visits before there was a significant increase in the patient's perceived level of function. I highlighted visit number 5 and 6 because that was when the patient first reported having a NPRS usual rating of 0 over the past 24 hours for the first time, and he reported a significant improvement in his perceived level of function based on his DPAS and PSFS scores. As you can see, the patient was doing very well by visit number 8. I'm sure that there are many possible mechanisms by which this intervention affected my patient's pain, and to be completely honest, I probably do not understand all of them. However, if I were to make an inference as to how I believe that this intervention decreased my patient's pain, I would reflect on the article by Mosley regarding the pain neural matrix. From this article, I would select at least 3 of these mechanisms: reduction of threatening input, non-nociceptive mechanisms, education, and assessment of progress. I believe that utilizing the TMR intervention to treat the uninjured limb decreased the activity of the injured limb and therefore reduced the amount of threatening input to the patient's left knee. This ultimately could have resulted in the reduction of pain signals to the neural matrix and resulted in less pain being perceived by my patient. I believe that educating the patient on the concepts of regional interdependence and cross-education in order to justify my implementation of this paradigm also influenced his pain level. I think that the patient truly bought into the treatment plan and trusted that it was going to not only decrease his pain, but improve his injured knee. Last, but definitely not least, I believe that collecting the outcome measures allowed the patient to visually see the progress that he was making day to day, and that further reinforced the improvements that were being made and helped decrease his perception of pain. If anyone has any other input in regard to this, I would love to discuss it. Since the patient's perceived pain intensity and level of function had improved greatly by visit number 8, I decided to perform some functional testing with the patient in order to determine if we would be able to start reintroducing him into football practice. I had the patient perform a jog around the field and then a jog, high knee run, butt kicks, walking lunges, double leg bounds, side squats, and zigzag runs for 10 yards each. I then had the patient do a 25-yard shuttle run 3 times. Then we simulated doing a run pass block to both the left and right sides from the 5-yard line all the way to the opposite goal line. The patient then ran around the circle at the 50-yard line 2 times in each direction. Lastly, we did 3 25-yard shuttle runs with the patient starting on his stomach. The patient reported that he felt good and had zero pain during and after each activity. Since the patient did well with those functional activities, he was cleared to start his return to practice. We increased his level of activity during practice each successive day since he was not having any issues. From this point on, the patient has been able to practice every day and play in every game after only missing 3 weeks. This is a table for the outcomes that I have collected on the patient since his discharge. As you can see, his outcomes have either stayed the same or slightly improved since he has been fully participating. At this point, the patient is coming in about 2 times a week to just continue performing some of the exercises that he did before starting practice. I decreased his visits per week since he is fully participating in practice, games, and team conditioning, so I don't want to have him overdo it. Here are some quick clinical pearls for you guys. Don't be afraid to try something new. A year ago, I would not have thought of training the contralateral limb in an ACL patient, but then this patient would have missed out on his senior season. Educating the patient on the concept of this intervention allowed me to gain his trust and to get him to buy into his treatment plan. If the patient does not believe in what they are doing, it is going to be an uphill battle the whole way. Collecting patient-oriented outcomes allowed me to provide evidence on paper to the patient that the intervention was not only working, but it also increased his motivation and his commitment to the treatment. Aside from the positives of this case, there are multiple things that I wish I would have done. I wish I had outcome measures starting at day 1 of the patient's injury. I am slowly working on getting my coworkers to buy into utilizing outcome measures on a regular basis, but I also should have just advocated that these were collected right away. I also should have identified some disease-oriented outcome measures like the Y balance for the lower quarter and goniometric measurements for active knee range of motion to collect throughout the patient's treatment. Also, I wish I would have videotaped at least some of the exercises that the patient performed in order to have evidence of the progression that he made. There are a number of other things that I'm sure I could have improved on in future cases, but overall I am happy with how this patient responded to this intervention, and I'm happy that he's been able to complete his season. Finally, here's a list of my references. Thanks for listening.